Welcome back. Okay, Dennis, we've already had a chance to talk about what diagnosis is, what's differential diagnosis, and also talk about some of the diagnostic terms that are now known, described by American Association of Endodontists. We took a little bit of time to describe some of the, pathological as well as histological basis of normal as well as abnormal pulp. And now we have a little bit of a foundational understanding of what we need in order to get into the first part of our diagnostic process, which is basically the patient interview.
Okay.
And the patient interview starts with the chief complaint. That's always the first step.
Okay, so let's talk about the chief complaint. Why is it important, and particularly, why is it important to register that chief complaint in the patient's own words? What's going on there that you want to focus on?
Well, the important thing to realize is the chief complaint encapsulates the reason why the patient is seeking our service. So we should never forget that. That is the reason why they're coming to see us. Oftentimes, there's all kinds of different kind of pathology involved with the patient, but if that's not the reason why they're seeing us, we shouldn't be focusing our attention to address things that may be true but may not be the source of the patient's complaint. So that's why the chief complaint should be written in the patient's own words, because it describes best what is the problem, which is the whole goal of what we're trying to do in a diagnostic process, to identify the problem. And it's not just for better identification. This is also a legal requirement. We need to have that legally written in the patient's own word so that we can capture information that we could then focus our attention to in terms of what's causing the pain and so on. For example, a patient can come to you and will, you walk into the room, as I said before, you have the assistant take the x-ray, have had the x-ray already. You look at the x-ray and you see a clear radiolucency at the apex of a tooth, right? For example, this tooth here, tooth number 30, your first molar, has had a previous root canal, and there is a clear radiolucency right at the apex of the mesial root.
My eye goes right to it.
Exactly. So that's the first thing you're going to see, right? And because that's just you're trained to see these types of anomalies. That should not be there. That's there. Patients coming to you is complaining of pain. And you're immediately going to say, well, that's easy. That's a failed root canal. You have to have it redone. But when you look at the patient's chief complaint, specifically in this case, the patient comes in saying that I'm in a lot of pain and I have had sensitivity, severe pain to hot and cold. This has been going on for a while, but it's just become extremely severe now over the past few days. So immediately when you hear that as a chief complaint, which is sensitivity to thermal stimulus, right, you can automatically assume that it can be associated with a tooth that has had a previous root canal. Now, we all know that there are cases, where a canal has been missed. You have an MB2 that has not been treated. But having a patient that has thermal sensitivity associated with a missed canal is really fairly rare. It's so rare that I don't recall really seeing one over the past 20-some years. Now, because part of the reason is because you need to have intact pulpal nerves. Goes back to the biology we were talking about here.
Right.
You need to have your A delta fibers intact. You need to have dental tubules intact, because the mechanism of cold sensitivity is movement of the fluid in the dental tubules. And if you've had if the whole coronal pulp has been removed, you're not going to have cold sensitivity.
Right.
So that is an important thing to realize. In this particular case, we realize that, well, the source cannot be the tooth that even the patient might be pointing to, because, as I mentioned also previously, pain could be a source of referral. A history of pain could be a source for a seeding ground of future experiences of pain.
I can't tell you how many times that I've had patients point directly to the tooth that has been previously treated, notwithstanding even a tooth or two in that quadrant away.
Yeah.
That is the offending tooth, and they are convinced. I mean, they say, no, this is the tooth.
That actually brings up a very good question, because the chief complaint is their problem, but the patient themselves aren't necessarily
making a diagnosis, right?
Exactly. It can't be making a diagnosis. Our point here is to understand what the problem is, and then try to associate all the additional information that we capture to put together a diagnostic picture, which is what really the whole point of this whole thing is. So once we have the chief complaint understood, then we are going to have to basically just get into the next step, which is the medical history review. Medical history is important, and it's important for two main reasons.
Okay.
Right?
What are they?
Well, the two main reasons are primarily, you want to know what is the medical history of the patient, what kind of medications they're taking, so that you may need to modify the way you're treating the patient. Patient management might have to be different
sure.
as a result of their medical history that they're presenting with. People that come in with a recent history of myocardial infarction, for example, they're going to have to be treated a little bit differently. You need to have a little stress protocol, things like that. If they're taking medication that may interfere with your work, for example, if they're taking some serious anticoagulants and you may need to do surgery, then these are things that you have to keep in mind that would alter the course of your treatment. But at the same time, there are also some conditions and medications that could contribute to the patient's chief complaint. They could either contribute to it or actually be the cause of it. So important to know what medical condition the patient has and review that systematically so that you can basically come back and be able to have a good, thorough diagnostics.
All right, so let me ask you this. What medical conditions actually require special management?
Well, we learn all of this stuff in our basic medicine course in dental school, and for that reason, we're not going to get into a lot of detail here during an endodontic diagnosis course, but, we always have to start by a systematic review of the patient's organs and systems, taking a look at the cardiovascular system, make sure the blood pressure, the vital signs, everything is in order, and, whether the patient needs prophylaxis or not. These are important things. A review of the pulmonary system, the hepatorenal system, the hematological system, the immunological system, and the neurological system are all very important.
Mm-hmm. Diabetes has become, such an important medical condition in terms of more and more of the population is coming into your office with diabetes. Just give me an example. Let's give our audience an example of how you might look at diabetes in a patient who's under management for diabetes and says, listen, I'm taking insulin and I'm doing these various different things.
Yeah.
Let's use that as an example of this kind of a thing, how you would handle that.
Well, diabetes, the most important thing to realize is the first question that you would ask them is what is their A1C level, what is going on in terms of the past history of their blood sugar readings and so on, and A1C is the best indicator for that right now. And you would look at it to make sure that things are under control, because an uncontrolled diabetic is is a very different kind of a immunological profile that you're dealing with, because these people are going to be far more prone to infections and healing interferences and issues that is not going to be easy. Also in terms of stressing them, whether they've taken their medication, they haven't taken their medication, they've taken their insulin that morning or not. All of these factors are important and you need to know. And I think for a thorough review of these management of the proper medical conditions, which we obviously not going to have time to go into today, would be to read a very good book titled The Dental Management of the Medically Compromised Patient. And I think there's a lot of good information, and it's a great resource to have in order to manage these patients better.
All right, so let's talk about medications more specifically. Will various medications actually influence diagnosis? Let's say let's say that a patient comes and their physician put them on an antibiotic.
Yes.
So give me just because the physician said, listen, you got to get to the dentist, but I can see you've got an abscess.
Yes.
Or you've got a swollen face, so I'm
Yes.
putting you on an antibiotic. So now the patient's in your office and they're not swollen.
Yes.
Okay,
and that's a very frustrating part of treatment, because oftentimes people put patients on antibiotics indiscriminately, and that masks the problem. So I think the best thing to do, of course, you have to make a judgment. Well, if a patient comes in with cellulitis on a tooth, you already have diagnosed the pain and you know where it's coming from, then it would be the right thing to do to put the patient on antibiotics immediately before referral. But when you don't have a diagnosis, it's very important not to put a patient on antibiotics, because for no other reason than also medical legal reasons, because we don't know where the pain is coming from. You can't put a patient on antibiotics without having a proper diagnosis as to whether, first of all, there is an infection, what is the source of infection. Antibiotics are not necessarily diagnostic on their own. They should be used as treatment, definitive or palliative treatment for specific conditions. So I think it's very important to understand that antibiotics can mask a problem. Unless you have a diagnosis, do not prescribe an antibiotic. And even the use of antibiotics is actually on decline in dentistry, because really the only indication for using antibiotics for pulpitis or even a periapical abscess is if the patient shows signs of systemic disease, because most periapical infections are fairly localized and there's really no reason to prescribe antibiotics for them, because the body, a healthy person
body,
with a good immune system can very well confine that infection. And the example of that is basically a big acne is really the same kind of infection as you would find in a periapical disease, right? I mean, you don't necessarily have to take antibiotics every time you have a little boil on your skin, right?
Yeah.
So the same thing goes with antibiotics in dentistry as well. It's been overused, and I think it's been used as a crutch when you don't have a diagnosis to give to the patients. And I think it's very important for people to understand, as a result of all of the changes that are happening, all of these drug-resistant bacteria that is developing as a result of overuse of antibiotics, we have to be far more conscientious about the use of antibiotics and apply it only in situations where we have a clear diagnosis, we have a clear pulpal and periapical diagnosis, and our periapical diagnosis is cellulitis and up, including infection to fascial spaces, uncontrolled systemic signs of infection.
So that being the case, how do analgesics and narcotics enter into this picture of influencing your ability to diagnose something?
Once again, patient who's been in a lot of pain takes 3 Percocets before they come in to see me.
That's not gonna work.
They're going to be in a different state of mind, as well as a different state of testing. They're going to respond differently to my test.
Sure.
Of course, some of the newer studies show that they may not influence the responses that much. But my experience, if somebody is on a high dose of anti-inflammatory and they're coming to me with an inflammatory problem such as reversible, irreversible pulpitis, making that edge of a difference between reversible and irreversible in terms of our testing, I think I'd rather have them not be taking any analgesics for a little while before, so I can have proper testing. Of course, the opposite end of that coin is a patient who is in pain may be over-responsive to some tests as a result of hyperalgesia. So I guess you're going to have to make a clinical judgment based on your patient and their own psychology and make a decision. But ideally, a patient that's not contaminated with antibiotics and analgesics is probably best for testing.
So if you've not been able to make a diagnosis, and obviously the right thing at that point is to have the patient go through to the next day or wait a little while, would you typically ask them not to take any analgesics that morning, or would you tell them it's okay to take something if you need it during the nighttime? Is that how you...
Well, yeah. I mean, obviously, the goal is not to make them suffer overnight, but to, before I see them for the testing, for them to kind of be off of the medication if possible.
Okay.
And I emphasize if possible, because again,
Pain
pulpal
can be pretty
could be pretty bad, and you can't ask people to stay in pain just because you want to do a little bit of a testing, and you may have an edge. So that's important. Also, some other medications that are basically medications that deal with either infection or our perception of infection, which is basically analgesics or neurotropic agents or any of these other medications that affect the sensory system, can potentially cause contamination of our results in terms of the reporting of the tests by the patient. So it's important to kind of have that in mind.
Yeah. So in getting a history of a patient on certain medications, the doctor needs to obviously be able to evaluate what effect those medications may have on the patient's symptoms.
Yes.
That's the key.
Absolutely.
All right. So they just can't discard and say, oh, well, the patient's taking a bunch of medications. More specifically, how's this going to influence? How's this going to alter my perception of what the patient's presenting?
Exactly. Because as we said, medications will affect both the way we're going to manage that patient, as well as, some medications, including antibiotics, analgesics, and some, sensory nerve kind of altering medications will have changes in the patient's symptoms, as well as potentially could be even the source of the patient's pain.
So I have a question for
yeah.
you. Let's talk to the audience a little bit about what types of things mimic endodontic pain or can mimic endodontic pain. What kinds of things would a patient present with that are going to ultimately be part of this differential diagnosis would I need to be aware of and have in my mind as potential sources of that are non-odontogenic?
Yeah, so, as we said, part of our goal is to differentiate odontogenic versus non-odontogenic, and then within odontogenic, find out what is the pulpal and apical status of the tooth. But while pulpal pain is actually fairly unique in its manifestation. Thermal responsiveness, pain to temperature changes, hot and cold, seems to be fairly unique to pulpal disease.
Okay.
But there is a number of other problems, such as generalized aches, pains in the oral cavity and in the surrounding tissues that could refer to teeth and could mimic tooth pain. A number of conditions, including temporomandibular dysfunction, myofascial pains, a lot of muscle pains actually tend to have this kind of a dull constant aching consistency about them that the patient's kind of unaware where it's coming from. It's diffuse, and it could easily be confused with endodontic problems. Obviously, sinusitis is one that everybody has heard about in the maxillary area. Your premolars all the way to the last molar. They could be sensitive to percussion and mimic a lot of pain in the area that only through testing of vitality testing in all the teeth in the area, you will be able to decipher whether it's caused by sinusitis or not. Sinusitis patients, and in fact, it's interesting because just the last week I had a patient who was third trimester pregnancy and came in with just a lot of pain in the maxillary right quadrant. And we were doing the testing and it was referred for a root canal on tooth number 3, the maxillary first molar, because it was very sensitive to percussion. The patient could feel it most on that tooth, and it had a fairly recent restoration. But we did the testing, and we found out, and look at the history of the patient. The patient claimed that she had a recent history of strep throat and a cold. And so that was an indicator that there's something more going on. And usually patients that have had either a recent history of bacterial or viral infections, their immune system is primed and they would respond a little bit differently as well. And in this patient, it turned out that the infection had spread to the sinus and they were having sinusitis. And so we found that out because a number of teeth in the maxilla were all sensitive to percussion. And although we could get palpation sensitivity on the outside, which is a hallmark of maxillary sinusitis, the pulps were all vital. So sinusitis is a very common problem in the maxilla. It doesn't cause pain in the mandibular teeth, obviously, but in the maxilla you can run into that a lot.
And the differentiation predominantly for that situation is you have multiple teeth that are percussion sensitive, even though they may not be identically percussion sensitive. There are multiple teeth.
Yeah.
And
oftentimes a history of sinusitis, somebody who's prone to it, a person who's recovering from a cold, has a cold, a number of these factors. But then primarily, you do your pulp vitality testing and you find out the pulps are all vital. And that is a really important thing because you can't have periapical infection and palpation sensitivity on a tooth that has vital, normal, responsive.
What I think is so interesting about this case that you just discussed is it's pretty logical to assume that if somebody's in an acute phase of a sinusitis, that it could affect the teeth.
Yeah.
But what you're really talking about here is that they're over the acute process of the disease, the more systemic disease, but yet they still are having a symptom that mimics an endodontic problem.
Absolutely. I mean, patients come to us with symptoms. They don't know the pathology. They just basically, what symptoms are basically are signs, manifestations of an underlying disease process. And our job is to identify the underlying problem.
Okay.
Taking the symptoms and find out what is the cause. That's the essence of diagnosis. And going back to some of the medical conditions that mimic tooth problems, if you look at the patient's history and the patient comes in and tells you that they have a history of neurovascular problems such as migraine headaches, a history of different kinds of headaches and things like that, these patients are very ripe for the kind of non-odontogenic pains that mimic odontogenic pain, right? These are the patients that have seen a million different dentists they come to, and that's why the history really is important. Because when you look at the medical history, you find out these patients have seen a lot of people, they've had similar pains, they have other problems such as migraine headaches and a number of other kind of neurological problems, different pain syndromes, whether they're neuropathic pain, whether they are neuralgias or fibromyalgia. These kinds of patients have oftentimes lots of related pain in the orofacial area that could get confused, and they may not know if it's from a tooth or not. Mm-hmm. So that's something, again, to have in mind. Also, immunological problems, as we mentioned, viral infections, as well as there's a pre-viral, kind of a herpetic outbreak or a pre-cold sore phase, that kind of aura that they have, that could cause a lot of neuropathy in some patients. And they come in and they have, they can tell you, it's like, my central incisor is killing me, for example. It's really sensitive. I don't know, I have a lot of pain in my premaxilla in the front area. You do your testing, everything tests normal. And then a few days later, suddenly they have an outbreak of a cold sore and the pain goes away. So it's important in those situations to be aware of these medical conditions that can happen. All you can do is to do your pulpal and periapical tests and come up with a diagnosis that is based on whether something is odontogenic or not.
Okay.
You can't diagnose everything in the world. It's one of the things I tell people oftentimes is that, my job is not to say exactly what's wrong with you, but I can basically tell you if it's caused by a pulp or by a tooth or not. For general dentists that are seeing patients, the first person that they should, if they can diagnose a case, should be sending the patients to their endodontist.
Okay.
Because the endodontist has a little bit more experience in these types of, the zebras and manifestations of the odontogenic pain that is not so common. So it's always best to just kind of filter the patient through the endodontist so the endodontist can see them, and have the endodontist basically refer the patient out, unless it's a situation that is completely clear. It's just this patient has absolutely no pulpal pathology, and a patient has no restorations, young, healthy, everything is testing normal. That patient, you could refer straight to their physician. Other conditions that I could basically name for you, uncontrolled diabetics have been known because of their compromised immune system to break out in spontaneous abscesses in the oral area. So being aware of the patient's history in that sense would be helpful. Patients that have pulmonary diseases, different things such as tuberculosis, for example, they may end up having lymphadenopathy that you test and you would mistakenly attribute to the tooth that may have a, that may not be the source. So understanding all of these things is important. Obviously, the classic example is the cardiovascular patient also of who's having an acute MI in your chair. They're coming to see you. They're having pain in the lower left jaw. And the reason for that is because the pain from the coronary artery disease that has now led into a myocardial infarction is being referred to the upper left jaw. And that's important to know, patient's history in that sense of having a disease process in the past. And so you can basically send them to the emergency room right away. Okay, so this basically is the ideas on the medical history and its association with the patient interview portion of the diagnostic process.
Okay.
As I mentioned earlier on, it's important to review maybe a textbook in this area about the management of the medically compromised patient. But for now, I think this should give us enough of an introduction to this area that we can basically use the information we've gathered from this stage and apply it to the next step, which would be the past dental history. So let's take a break and come back and take a look at the past dental history and what is it that we're trying to capture from the patient during that interview session.
Sounds good. Thank you.